Welcome. This lecture is on the pharmacist and the pharmacy profession. This is chapter 3 in the new 6th edition of Introduction to Healthcare Delivery, a primer for pharmacists by Kimberly Plake et al. This is our 30,000-foot view of the entire healthcare system. And pharmacists are obviously part of the entire healthcare provider system. You can see all the other entities involved, which we will get to in the future. And then professionals, as professionals, pharmacists, physicians, nurses, and many of the other healthcare professionals fall under this category. Back in 2010, CUW-SOP had their first entering class, the Genesis class, and their guest speaker for the white coat ceremony was Peggy Wiederholt. Her husband, Joe Wiederholt, was a distinguished pharmacist, was a lecturer and professor at the University of Wisconsin-Madison, and he was an author of several topic areas, including professionalism. And in one of his writings, he had the 10 pearls for achieving professionalism. So that was a focus of the white coat ceremony talk back a number of years ago, which today is very relevant for every professional, not just pharmacy, but others as well. To underscore one of the main points of Peggy Wiederholt's speech and the work that her husband did on professionalism is that professionalism is an unconditional dedication, a commitment to excellence to the patient. So if you can remember those two things, it will be a good start to your pharmacy practice careers. And specifically, here are the 10 pearls for achieving professionalism. If you can keep these close to you and always look upon them as guidance as far as excellence and commitment to the profession and patients. So 1, passion for your profession. 2, share your efforts through various mechanisms, scholarship, community service. Always lead by example. Learn to say I don't know. I mentioned to you that it's not something that you should feel ashamed of if you don't know something. In fact, it is better to say I don't know than to say something that is untruthful and blatantly lying. So dream. So dream to create your own vision. I think dream also helps to let yourself be creative and to innovate. You want to listen with an open mind. Don't be afraid to take risk. Here again is that word commitment. So commitment to excellence and quality to your patients. Build communication bridges. Be a problem solver. And be a team player. And then lastly, maintain that integrity. You want to be trustworthy. You want to be respectful, and in that case, people will also be the same towards you. So what is a profession? Not all healthcare professions are necessarily deemed by professions. Pharmacy was one of those professions. And professions, they don't just do one thing. They're not just focused on one thing. They have various objectives other than to serve society. So merely providing services doesn't mean that you're being professional. You must you must do other things. You must have a certain mission, certain values that you adhere to. What are the characteristics of a profession? So here are some characteristics that are deemed to be part of somebody's profession. They have to have systematic theory and knowledge. So research and experiments have been the basis of knowledge in that profession. You have authority and privileges as a result of your expertise. You have certain sanctions and social utility as a result of your status and power. You must adhere to certain ethical codes and internal controls. These help guide your practice as well as your profession. And then, there's always kind of an inherent culture to your profession, to your organization. So you guys will be having a white coat ceremony coming up soon. Congratulations for making it this far. All the best to you in the future. And not too long ago, academic administrators in health professional schools, in particular medical schools, noticed that there was a lack of professionalism in some medical students as a result of inappropriate dresses or their inappropriate look. Wearing a t-shirt and baseball cap and gym shoes doesn't necessarily scream, I'm here to help you. I'm a professional that has an expert in X, Y, and Z. So it's just been recent that many professional programs have undergone to this white coat ceremony. And the ritual got started at the University of Chicago in 1989. Okay, just a quick question here. A professional's preparation and duties are likely to include all of the above: specialized skills, continuing education, a basis in scientific theory, and credentialing. The motivation of a professional shares this theme with Concordia's mission. And primarily it is service to others. White coat ceremonies are primarily intended to increase professionalism. Okay, so as pharmacist, you will obtain the PharmD degree here at CUW SOP. That has been conventional in the last decade or so. However, there are some schools with, instead of a 4-year program like you are here, there are some schools that have gone to a 3-year. Basically, this is like an accelerated program. In fact, MCW School of Pharmacy, that's opening up here in the near future, is planning to have a 3-year program. Your licensing, after passing the NAPLEX, you will be a registered pharmacist. So it is awarded by each state, not the school. And then some of you might think that you might have other interest in other disciplines, and you have an interest in possibly pursuing residency or fellowship, as well as obtaining an additional degree, a graduate degree like the MPD, which is the Masters of Pharmaceutical Product Development, an MBA, Masters of Business Administration, MPH, Masters of Public Health, and there are several other graduate programs that can be integrated with your PharmD, and we call that dual degree or joint degree. There are various certifications that a pharmacist can undergo, and you'll learn those throughout your time here as well. So the NAPLEX, the licensure exams, are from the National Associations of Boards of Pharmacy. Both these two exams, the NAPLEX and the MPJE, which stands for Multi-State Pharmacy Jurisprudence Examination, or the law exam in pharmacy, are taken through computer-based adaptive testing. So NAPLEX is used in all states, and the MPJE is almost in all states. And then there are some states that require additional testing. So the boards of pharmacy specialties recognize 6 specialty practice areas. Ambulatory care, this was set in 2011. Nuclear pharmacy, so that would be somebody who seeks to improve and promote the public's health through safe and effective use of radioactive drugs and diagnosis. There's also nutrition support specialists, promote the maintenance and or restoration of optimal nutrition. Oncology pharmacy, so this is somebody who specialists recommend, design, implement, monitor, modify pharmacotherapeutic plans to optimize outcomes in patients with malignant disease, i.e. cancer. Pharmacotherapy, this is a specialist responsible for ensuring safe, appropriate, and economical use of drugs in patient care, and frequently serves as a primary source of drug information for other healthcare organizations. Psychiatric pharmacy, specialist address the pharmaceutical care of patients with psychiatric disorders. And then lastly, sports pharmacy. So there are a few residencies that have this designation. And if you have an interest in this, let me know and we can certainly help you. So when you graduate from Concordia, you will be eligible to sit for the licensure and take the NAPLEX and the jurisprudence exam. And of course, like many exams, you will have to register and take the NAPLEX on your own and when you are ready. Just a bit of switching gears. I know we talked about history in the introductory lecture, but we didn't talk a whole lot about pharmacy history. And I think it's important to understand where, how, who some of the important events and players are in pharmacy history. So the word pharmakon, or pharma, pharmacy, pharmakon, is a Greek word for remedy, poison, or magical charms. One of the more important U.S. acts is the Drug Importation Act of 1848. So this was in response to efficacy and safety issues experienced by U.S. troops in Mexico during the Mexican-American War. So it is the first law surrounding any issues regarding drug importation. As far as the profession, one important person that helped develop the profession of pharmacy indirectly was Dr. Abraham Flexner. He was hired by the United States to conduct an analysis, a report of the healthcare system in America, which included assessing medical education, pharmacy education, and the like. And out of that report, one of the things that he declared was that pharmacy was not a profession. So obviously, that was kind of a slap in the face to pharmacy. And from then on, there was a great deal of positive movement by the pharmacy profession to make it more professional. Right around that time also, the U.S. War Department decided that registered pharmacists would not routinely receive commission because their professional education was minimal. So before the 1940s, there weren't any credible standards and enforceable laws regarding the safety of therapeutic agents. So the very first legislation that tried to manage, legislate, control, regulate drugs was the Pure Food Drug Act of 1906. It was not comprehensive. There were many loopholes, and it did not address efficacy. So how efficacious is the drug that you are producing? During this time period, there was an important event, an unfortunate event. So we call it the elixir sulfanilamide scandal of 1937. And this scandal was as a result of this sulfanilamide, which is an antimicrobial, and it was safe to use in earlier formulation, but this new formulation that they titled elixir sulfanilamide, it was very toxic as a result of a particular toxin in there, and cover that in the next slide. So this scandal, this event that caused almost 100 deaths, was the genesis and the impetus for the enactment of the Food, Drug, and Cosmetic Act of 1938. So this is the synopsis of the elixir sulfanilamide incident. And again, initially, the initial formulation was safe and used for many years, but this new oral preparation that had diethylene glycol, which is a major constituent of antifreeze, that's what caused the near 100 deaths that included some children, unfortunately. So even again at this time, there wasn't any regulation on safety and even health outcomes data to be conducted by the manufacturers of these drugs. So that caused obviously some untimely events, including this one where there was improper labeling of this elixir instead of a solution. So that is actually part of the issue at hand, is kind of the labeling of this particular drug. And that obviously spurred the passage of the 1938 Food, Drug, and Cosmetic Act. And with this incident is what finally perpetuated and put this act into law. Took a while, took over 6 years, but this unfortunate incident caused the passage of this act. Now, it obviously there was going to be more laws and regulations, more authority for enforcement by the FDA to approve new drugs and indications. There were certain standards of safety and efficacy. For example, determining the LD50, so the lethal dose of a particular drug, testing in animals that would indicate its toxicity, and obviously also to start to demonstrate the efficacy of particular drugs. And at this time point, there was no categorization of prescription and non-prescription. Fortunately for pharmacy, if you can imagine this time, again, around the Great Depression era, where the economy and the recession really took a toll on every industry. And that made the role of pharmacist even a little bit more apparent and were important in terms of healthcare, advice, medication recommendations, so that pharmacists had indirect prescribing authority just because some people couldn't afford to pay a doctor, for example. Between the 40s and the 70s, again, as a result of especially Dr. Flexner's report, the pharmacy curriculum became a little bit more scientific. It became more evidence-based. The degree itself went from 4 to 5 years. There was an expansion of the scientific curriculum: medicinal chemistry, physiology, pharmaceutics, pharmacology, pharmacokinetics. So all this science that were established in some of the basic sciences, chemistry, biology, they legitimized pharmacy research and pharmacy practitioners, and along with new drug testing methods set forth by the FDA and the FDCA Act, things were becoming more professional for pharmacy. Fast forward to the 70s, there was kind of another landmark events that occurred for pharmacy. There were these 3 reports. So the first one is the Mirror to Hospital Pharmacy. The second is the Deichter Institute study. The second, the Mills Commission's report. So these 3 reports helped again for pharmacy to evolve, to self-assess, to progress. So the Mirror to the Hospital Pharmacy, it also talked about how pharmacy can be more professional, can be more of a profession. There was a study on student satisfaction in there that helped guide this report. The Deichter Institute report, interestingly enough, it assessed how respondents, survey takers, saw pharmacists as more businessmen rather than healthcare providers. And you can imagine how, this is kind of obvious in a sense, how the evolution of the pharmacist, the corner drugstore, again from the point of the Great Depression, where pharmacists were utilized for many aspects of healthcare, including diagnosis of their diseases as well as their prescriptions, dispensing of their prescription medication. The Mills Commission report. So one of the outcomes here indicated that pharmacists were inadequately prepared in systems analysis, management, and communication skills. We'll talk more about this as we go on through the semester, but systems analysis, management, and communication skills all kind of relate to business administration, administrative sciences, and communication sciences. Altogether, there's a little bit of a disconnect with pharmacists in these sorts of sciences, for example. The profession kind of blamed itself because that they concluded that pharmacy is all over the place, and that we're not emphasizing training and expertise in patient care enough. So that's where the movement for clinical pharmacy and for pharmacists to be therapeutic advisors started to evolve. Colleges at this time increased the number of post-BS PharmD programs for clinical pharmacists. And these clinical pharmacists primarily practice in hospital, providing pharmacokinetic dosing, therapeutic monitoring, drug information services. So you can see how in a hospital where a trained pharmacist in this area would be really good for the profession in terms of interacting with other professions such as physicians in terms of team-based care. Finally, towards around the 90s is where the PharmD became the entry level degree. Another important act in healthcare is the HMO Act, or the Health Maintenance Organization Act of 1973. And this increased the prevalence of managed care and helped to instill a culture, a business environment of cost containment. So I have mentioned in our earlier lectures regarding moving from fee for service to bundled payments and capitation. So those ideas of financing for healthcare come into play when it comes to the HMO Act of 1973. So it did obviously help to improve in managing people's care in an efficient way, reducing some cost, but there were obviously some drawbacks. Along the same time, you'll hear this term diagnosis-related groups. So these are taxonomy or definitions of diseases or disease states for Medicare patients, and it helps to create a prospective reimbursement schedule for disease states, and it's dependent on the length and intensity of care. The DRGs, however, created an incentive for hospitals to discharge patients sicker and quicker. So that meant that because the government was only going to pay a set amount for a particular disease state for a particular patient, there was no incentive for hospitals to keep a patient at the hospital for a longer time period. In fact, it's the opposite, right? Because they're getting paid at a certain amount, you want to kind of rush the patient out the door as soon as possible. So that's the idea of they're sicker, they might be sick still, but quickly get them out of the hospital. In the 21st, fast forward to kind of current time, modern, millennial times, the Medicare Part D, part of the Medicare Prescription Drug Improvement and Modernization Act in 2003. This was a landmark act that helped to provide additional coverage for the elderly who qualify for Medicare. Now they were going to have certain medications covered for. This included some provisions of medication therapy management, otherwise known as MTM, which you will learn more about throughout your entire program here. And of course, we can't leave without saying something about the Patient Protection and Affordable Care Act of 2003, as well as along with that there was another act, the Healthcare and Education Reconciliation Act, that goes kind of hand in hand with this. But Obamacare as we know it is the Patient Protection and Affordable Care Act. Interestingly enough, again, the professionalism of pharmacy, the provider status of pharmacy, and pharmacy's advocacy for pharmacists providing more MTM became a reality in 2007 when it became a permanent CPT code, which stands for Current Procedural Terminology Codes, and we'll learn more about that in the future as well. And this is just showing you an outline of 100 years of continuous evolution to meet society's needs. Things that we've already talked about quite a bit, the progression of the professionalism of pharmacy. So look this over and understand the history behind the profession that you're going into. The context in which clinical pharmacy emerged, so interestingly enough, look at the code of ethic. So the pharmacist should never discuss the therapeutic effect of a physician's prescription with a patron or disclose details of compositions which the physician has withheld. So that was something that pharmacists should never do, is never discuss therapy with a physician. And now fast forward, new code of ethics starting in 1969. Again, to enhance professionalism, a pharmacist should always strive to perfect and enlarge his or her knowledge. She should always utilize and make available this knowledge as many may be required in accordance with his or her best judgment. Okay, 1915, Abraham Flexner declared pharmacy was not a profession. You know that. Again, very important in the whole area of healthcare reform back in the turn of the century. The Pharmacist Code of Ethics at one time stated that a pharmacist should never discuss therapeutic effects. It's true. The passage of Medicare and Medicaid led to an increase in the number of prescriptions. This is just a video to show you some roles and responsibilities of pharmacists. What does a pharmacist do? Okay, so changing the topic a little bit in terms of how a pharmacy school gets accredited. How or what pharmacy schools need to do in terms of educating their students so that they are an accredited pharmacy school producing licensed pharmacists who successfully pass board examinations. So you might hear this time and time again regarding this is our pharmacy curriculum Bible, if you will, what we call the CAPE outcomes. So the CAPE outcomes, CAPE stands for the Center for the Advancement of Pharmacy Education. And this is just, in 2013 is the most recent iteration. Before that, 2004, it took a while. It takes about a decade for the assessment and basically a redoing of outcomes, and these outcomes are definitely a little bit more descriptive and very prescriptive, if you will, versus the 2004 outcomes. So there are certain foundational knowledge that you need to know. So the basic sciences, again, some of the medicinal chemistry, anatomy, physiology, pathophysiology, pharmacology. There are essentials in the practice and care, approach to practice and care, and personal and professional development. If you just Google CAPE, Center for Advancement Pharmacy Education, Educational Outcomes 2013, you can see the entire report. So pharmacist in research. Research is important not only in discovery, but it guides your practice. You do what you do as a result of research. You practice pharmacy as a result of the research that has occurred. And one of the things that you practice in terms of pharmaceutical care, so this is where clinical pharmacy is still focused on products and services rather than on patient care. So when first initially developed the mandate for pharmaceutical care, it wasn't necessarily that the patient was at the center, where now in current times we want to put the patient at the center, that we do want to focus in on the patient. So that's a good distinction of pharmaceutical care in the past and now, is that the patient now is at the center. The medicalization and increased reliance on drug therapy has both adverse effects. These are negatives or disadvantages or drug misadventures versus its benefits or advantages. So we obviously have always contraindications and adverse drug reactions, potential hospitalizations, potential issues of adherence and compliance, as well as ultimately death if the drug is toxic to the individual, or potential overdose. So pharmaceutical care is the responsible provision of drug therapy for the purpose of achieving definite outcomes that improve a patient's quality of care. Quality of life, excuse me. So now fast forward. This is a more appropriate definition of pharmaceutical care, where there are some outcomes and basic functions. So outcomes include help to cure the disease, eliminate or reduce symptomology, arrest or slow the disease process, prevent the disease. Again, I'm going to underscore prevention as a public health, population health scientist and my area of expertise. So it's kind of a conundrum for pharmacy. If you do a lot of prevention and you get rid of chronic disease altogether, you might be out of a business. Think about that for a second. And of course, some of the basic functions in pharmaceutical care include identifying potential or actual drug-related problems, resolving actual drug-related problems, preventing potential drug-related problems. Fast forward to post-pharmaceutical care, we come to the era of medication therapy management. So medication therapy management has become more of a definitive responsibility, definitive outcome versus pharmaceutical care that is a little bit more nebulous in comparison. So the emphasis, the medications in public health and in safety, yet it also recognizes the collaboration, the team-based nature of pharmacists with other healthcare professionals. So there are models that have been implemented and some of the services that have been proffered as a result of MTM in comparison to other models such as pharmaceutical care. So now MTM is kind of the more proper term with respect to anything related to pharmacist duty and managing medications. What are the barriers? When we look at pharmaceutical care, it's drug focused, it's service focused. Sometimes that we feel like there is other healthcare professionals that may have some political issues. There may be some incentives that could compromise the service as well as compromise the patient, as well as compromise business ethics, for example. And then logistical, so meaning over time, the pharmacist has traditionally not necessarily been involved with consultations, disease monitoring, and providing drug information. So all these are issues that we've done quite a bit of education on so that we can move beyond these barriers and into kind of 21st century team-based interprofessional care. We have already mentioned the Medicare Prescription Drug Improvement and Modernization Act of 2003. This obviously helped with the financing of medications, so the financing, the reimbursement of medications that helped provide, money basically for the profession of pharmacy and the related activities in terms of pharmaceutical care, MTM. Whenever you talk about pharmaceutical care and medication therapy management, disease state management in pharmacy, one of the seminal studies that should always be referenced is the Asheville Project. So this was a private sector venture where pharmacists were reimbursed for pharmaceutical care, in particular diabetes, and the study indicates some of the outcomes in diabetes, for example, the improvement of hemoglobin A1C, as well as the cost savings that this particular project did for the business. Lastly, I want to talk about pharmacy workforce. We study the workforce because that's why Concordia opened up. There, a whole decade ago almost, when Concordia was looking at starting a pharmacy school, pharmacy was one of the professions that there was a need to develop, to educate pharmacy students. So at that time, we use certain economic factors in terms of supply and demand of workforce. And you can see what are the pharmacist demand factors. So what are the pharmacist demand factors? So they expected to increase in overall drug prescription. There's going to be an increase or redistribution of practice locations, need for professionals to provide pharmaceutical care, MTM, more technician availability, and therefore you need to control that ratio of technician to pharmacist. There's going to be a high degree of technology improvement, so we need to train future pharmacists for that. And healthcare reform is going to revolutionize the practice of pharmacy. It's going to address the issues of pharmacists having provider status, for example. So pharmacist supply factors include increasing the number of pharmacy schools. We know that there's a high degree of retirement for the aging workforce, the increasing female workforce, and the movement professionalism for PharmD as a standard of a degree training versus the registered pharmacists, as well as the corporation of community pharmacies. So this is back in 2014 when you can yourself look at the source, the pharmacymanpower.com website, to determine the demand, supply demand, or the demand for pharmacies. You can see the rating there from 1 to 5. So 5 being high demand, it's difficult to fill the position, all the way to 1, the demand is much less than the pharmacist supply available. So in Wisconsin, 2014, it was exactly 4. So there was a moderate demand, some difficulty filling open positions. And this makes sense. As we graduated our first class in 2014, I believe almost all got a job or started residency right as they graduated or within 3 months of their graduation. And you can see the improvement from 2011 to 2014 in terms of the demand. What factor caused that decrease, or what factor caused the increase, to look at it a different way? Obviously getting out of the recession that we were just in. Here's more information about pharmacy workforce. So what segments are pharmacists practicing in? Are they in dispensing? Are they a dispenser who also provides patient care? So this is just showing you a survey from the National Pharmacist Workforce Study, showing you the proportion of the 2009 workforce. So as dispensers, in terms of dispensing time, in that very first set of bar graphs, that the proportion of the 2009 workforce spent quite a bit of time in dispensing role and very little in patient time in patient care. And then, however, if you look at the other end of the spectrum, meaning that pharmacists who are more in a provider role, perhaps a hospital pharmacist or ambulatory care pharmacist, they spend quite a bit of time in patient care and very little time, almost the opposite of the dispenser role. So these are some nice data to demonstrate to you the quite diverse nature of the responsibility of pharmacists. And this is just showing in what setting are pharmacists practicing in: community versus hospital versus other. This concludes the lecture for today. Thank you very much.